Welcome everybody to New York. Before I start, what you heard from Dr. Sharma is probably the best talk you're going to hear this year on the review of interventional cardiology. He summarizes that in 30 minutes is just astounding, and all the salient points and everything he talks about in the summary is true, so really impressive. So I'm going to talk to you today a little bit of a shift of gears about invasive coronary function testing and what this means in 2024. Let me go forward here. There we go. These are my disclosures. So I'd like to start this talk with two cases. For those of you that don't know what coronary function testing is, these are the cases that are going to illustrate this and will help define that. So these are real cases. This is a 52-year-old female who's a prior smoker with hypertension, high cholesterol, depression, and rheumatoid arthritis. She was treated by her cardiologist with regular medication, rosuvastatin, glucophage, pantoprazole, and aspirin. She presented now with recurrent episodes of shortness of breath, angina during exercise, and stairs. She'd been to the emergency room 7 times in the past 2 years for chest pain, and each time she left with a quote, "This is non-cardiac. Follow up with your cardiologist." So she saw her cardiologist, she saw a pulmonologist, she saw a gastroenterologist, a rheumatologist, and eventually a psychiatrist. Her cardiovascular workup actually included pretty comprehensive testing, was a nuclear stress test that showed some mild anterior ischemia, and a left heart catheterization that was done that showed non-obstructive coronary disease in the LAD. And this was done with physiologic assessment. So she sought a second opinion, actually a third opinion, for her persistent chest pain. The second case is a 60-year-old female with hypertension, high cholesterol, and diabetes. She came in with intermittent chest pain, squeezing sharp quality, with exertion and some shortness of breath. She had a stress echo that was positive by an EKG. However, the contractility was normal, and overall the read was negative for ischemia. She underwent a coronary angiogram at another hospital a few years back, which showed quote-unquote normal coronary arteries. And she was maintained on ranolazine for presumed, quote, microvascular disease, but remained very symptomatic with daily occurrences of chest pain and 2 subsequent ER visits in the past year before I saw her. So the whole notion of angina with non-obstructive coronary disease has an acronym called ANOCA. For some of you may know that, some of you do not. So my goal today is kind of to describe what is it, why do we care about it, how do we diagnose it, and how do we treat it. So what is ANOCA? So ANOCA is kind of boiled down to this slide where we talk about myocardial ischemia in 2024. And one of the important trials that led to this, so first off, angina pectoris is a very common symptom. 100 million people worldwide have angina. And this trial took 400,000 patients with angina and did an upfront coronary angiography as the initial test. And guess what they found? Defining obstructive coronary disease as anything greater than 50% stenosis, 63%, almost 2/3 of those patients had non-obstructive coronary disease. And majority of those patients were females. So what we took 2 take-homes from this pretty impressive trial. One is coronary angiography alone is not enough to just determine what the cause of chest pain is. And number 2, when patients have repeat coronary angiography, the economic burden is enormous on the patient and on the healthcare system. So non-obstructive coronary disease and chest pain has these phenotypes, and the phenotypes are what I described to you as ANOCA, that's angina and non-obstructive coronary disease, or MINOCA, and that's a patient with a myocardial infarction and non-obstructive coronary disease. You'll see these terms kind of used interchangeably. And it's brought this term called open artery ischemia, which is a great term that we use now to describe this phenomenon. And ANOCA has 4 different endotypes. And these endotypes you'll hear about. One is microvascular dysfunction, or microvascular angina. The second is vasospastic angina. The third is a mix between microvascular and vasospastic angina. And the fourth is a myocardial bridge. So these endotypes help make up this entity of ANOCA. And what we're determining, or we're finding out, is it's really important to find out which patient has which endotype. And probably the take-home message here these patients are a real challenge to take care of. It's a very difficult diagnosis to make, and more importantly, a very difficult diagnosis to manage as an outpatient. So how common is this? Well, there's been a lot of literature out there in the years prior, but this study, 15,000 patients with non-obstructive coronary disease, up to 40% of those patients have either vasospastic or microvascular dysfunction. And this is both in a non-invasive, in the blue, and invasive cohort. So it's a pretty common and prevalent entity, and if we turn our back to it, we're going to miss it. So why do we care about this? Why am I up here talking to you guys about ANOCA? Well, ANOCA is not benign. It is not, oh, you have non-obstructive coronary disease with chest pain, you'll be fine, you're never going to have a heart attack. And that's not true. And this was determined in the landmark WISE trial. This was Women's Ischemic Syndrome Evaluation out of Cedars-Sinai a few years back. This was 1,000 patients, stable symptomatic women with ischemia. They underwent just medical therapy, and what they found out in those patients on the right, the curves, those patients with non-obstructive coronary disease, the middle curve had an 11% cardiovascular mortality. So 11% patients died of a cardiovascular reason that had non-obstructive coronary disease. So it's a very, very important entity to diagnose, and it's important not to underestimate it. In addition, we're finding out that ANOCA, or microvascular disease, so forth, has implications of other cardiovascular disease, such as HFpEF, atrial fibrillation, obstructive coronary disease down the road, heart failure, Takotsubo cardiomyopathy. Some of these have very close links now to microvascular dysfunction, or ANOCA. So we're learning more and more about this disease. Is it the chicken or the egg? We're not sure yet, but it's a very interesting question to ponder. Next thing is, how do we diagnose this? And this is where I come in. So the best way to diagnose this actually is in the cath lab. And the reason why is we're able to look at two different mechanisms of myocardial flow. We look at both endothelial independent mechanisms, and that's the curve on the left, and we do this by providing a medication called adenosine in the cath lab, and we look at how the microvascular behaves, and then we switch gears and give endothelial dependent testing, and that's through intracoronary acetylcholine, and that allows us to assess for vasospastic phenomenon. So it's very, very important to take these patients to the cath lab and do a comprehensive physiologic testing, and that's where this term coronary function testing came from in the past few years, to help kind of delineate how these patients should be treated and tested. So what am I referring to when I talk about coronary microcirculation? Well, this is a picture of a coronary artery on the top. We're all very familiar with the epicardial arteries. We see them when we do an angiogram, but what we don't see is blind to the eye, and those are the prearterioles, arterioles, and capillaries. And what we've determined, or what has been determined, is 95% of the resistance in that coronary bed is in those arteries that we don't even see. So just because we see an angiogram with an epicardial artery running down to the front of the heart and the LAD as normal, that's not telling us much as a reason the patient may or may not be having chest pain. And we have to assess how the resistance is in the capillary bed and in the microcirculation. So I'd be amiss if I didn't say there are non-invasive ways to test for this. There are, and they've been around for a while. We have PET scans, we have cardiac MR, and we have echocardiography. The problem is most of those non-invasive testings, except for a few places, do the endothelial independent mechanisms. So they're testing more for microcirculation or microvascular, not necessarily vasospasm. So that's why it's important to do both arms of the testing, and that's what we can do when we come to the cath lab. In the cath lab, the way we look at the microcirculation from an invasive perspective is we look at something called coronary flow reserve. And if you look at the curve on the right, those patients that come in with chest pain and non-obstructive coronary disease have much worse outcomes or elevated major adverse cardiovascular events with an abnormal coronary flow reserve. That's the top curve, versus those patients with a normal coronary flow reserve. And that's a very, very important representation to look at, because this is the crux of it, is these patients have poorer outcomes. And now in the cath lab, over the past few years, with the help of Abbott and a platform that they provide to us, we're able to assess a new index called the Index of Microvascular Resistance. And I'll describe to you what that is, which is a little bit more specific for the microvascular system than just the coronary flow reserve. And even more recently, we're using coronary flow as an absolute measure. So we're actually infusing saline down a coronary and measuring how the flow is. And that is actually coming out now. So as I mentioned, coronary flow reserve was really the hallmark way we measured flow resistance. The problem is coronary flow reserve looks at the entire coronary artery. So if you have a stenosis in the epicardial artery, it's going to affect the flow reserve downstream. So it got a little murky. CFR measurements were not very reliable. There was a lot of intervariable independence or interdependence upon patients that had it done a couple times. And so the index of microvascular resistance is actually a measure So the IMR is a measure that's something that's more specific of the microcirculation. It doesn't take, it is able to control for any epicardial stenosis or non-stenosis for that matter, and very, very specific. So it's a better measurement of the microcirculation. And it's readily available now in most cath labs. It's very specific, it's very reproducible, and more importantly, it's actually very predictive. And in one of the initial trials, those patients that have a elevated IMR, so that's a number that we use that tells us the microcirculation is not doing what it should be doing, it's not dilating to increase flow, they have worse outcomes. That's this purple curve or these purple dots in the lower right quadrant. And this has really sprung a new field of coronary function testing among all patients now with chest pain. So a lot of this technology was brought to us by Abbott. This is the platform that they provided to us. This is a Coraventus platform that's using a wire with a pressure and temperature sensor on it. And we put this wire down the coronary and we get a readout. And when we put the wire down, we give injections of saline at baseline, and that gives us how long the saline takes to go down the coronary artery. And then we induce hyperemia by giving adenosine. And then we see if the microcirculatory system dilates and we're able to augment flow. And it's a simple calculation. And you see the baseline flows in blue and then the hyperemic flows in orange. And then it's a simple ratio calculation. And the nice thing about this platform is it gives us these numbers. So it gives us a FFR, which tells us that this is non-obstructive if it's greater than 0.8. It does calculate a CFR, which is the coronary flow reserve. Anything more than 2 is normal, meaning that coronary system is able to augment flow twice as much as what it is at baseline. And then it gives us the index of microvascular resistance. So anything greater than 25 or 28 is considered abnormal. You want to have it less than that for something normal. So in this patient that was done right here, this is any particular patient, this was a very elevated IMR of 32. So this patient had microvascular dysfunction. So this is a quick test. It takes about 5 minutes. You do have to induce hyperemia, but it really gives a lot of information and physiology of the vessel. We then switch over to the provocative testing. So this in the past historically has always created a lot of anxiety for patients in the cath lab, for staff in the cath lab, the doctors doing the test, because it has some risks associated with it. And this is a test that we're doing to assess the endothelial-dependent mechanism of microvascular dysfunction, or of ANOCA, if you remember. So the way we do this is we obtain a formulation of acetylcholine. We get this from our pharmacy. It's actually an intraocular formulation. And then we dilute it. And these are the dilutions over in the right side of the screen here. And then we infuse this directly down the coronary artery. we do an intracoronary infusion with our hand, and then we assess how that coronary artery is responding to each dose. The important thing is this is a very, very safe procedure. And if it's done in the right hands and it's done carefully and safely and in a program that has a protocol in place, this has been shown to be very safe. The side effects that we see, very minor. Sometimes it can cause sinus bradycardia, sometimes AV block, a few cases of transient atrial fibrillation, but these are overwhelmingly very short-lived and actually go away as you slow down the infusion of the intracoronary acetylcholine. But the major complications, the refractory spasm, ventricular fibrillation, are very, very few. And that's very different than what it was in the past. And I think the current protocols really tame the safety of this procedure. So the way we do this is we bring a patient in on the screen on the left. We do an angiogram, a coronary angiogram. We then put a wire down to assess the endothelial independent mechanisms. We give adenosine, and we assess the microcirculation. And then we take the wire out, and then we administer acetylcholine, and we test for vasospasm. And at the same time, we see angiographically if there's a bridge or not. So just by doing those three things, we have now covered all the endotypes, different types of endotypes that a patient with chest pain and non-obstructive coronary disease could have. And that's a very, very powerful thing to see and to diagnose. So how do we treat it? So this is where we have a lot of information, or we need a lot of information, a lot of help. We need to recruit patients for our studies and our registries to help determine what's the best treatment for this. But we do know that in some trials that have been done, there's been a nice paper written in JACC summarizing this, that patients with coronary microvascular dysfunction really should be treated with, as you can imagine, risk factor control, weight loss, stopping smoking, so on and so forth. But these are the patients that benefit from beta blockers. And in particular, nebivolol is probably the preferred beta blocker because it has a component of nitric oxide donor. And those are the patients that we should start right on a beta blocker. In the patients with epicardial spasm, so we give acetylcholine and we see that they spasm, these are the patients we're going to start with a calcium channel blocker, preferably dihydropyridine calcium channel blocker, and we titrate that up to dose effect. So we titrate to see if they can become asymptomatic to it. Sometimes we do add on a nitrate, a nitro patch, or a sublingual nitro, or a long-acting nitrate in addition to that. And then when it comes to myocardial bridging, usually we start with a beta blocker as well on that. But that's a little bit of a different entity than the first two. So these are really the three endotypes that we see. The fourth one is a combination of both. It's a really tough endotype to treat because it involves both mechanisms and both physiologies. And we now have guidelines that support the use of this. So gone are the days where we think about chest pain as mostly of just ischemia and doing an ischemic workup. The guidelines now shifted to looking at patients with non-obstructive disease or this open artery ischemia type phenomenon. And it's given now a 2A indication to take patients to the cath lab, or while they're in the cath lab getting an angiogram, to start looking for reasons for chest pain that are beyond just a blockage. And that involves the coronary flow or coronary function testing. So just to summarize or to finish our last two cases, our first case, this was the patient with chest pain. She had ER 7 times. She was told to see a psychiatrist and came to me for a second opinion. We brought her to the cath lab. We confirmed that she did not have any coronary lesions. Her right coronary artery was normal as well. We then started with the coronary function testing with the endothelial independent mechanism by giving adenosine. And her readout was here. She had very minimal augmentation of her coronary flow, and she had an IMR of 32. That's greater than 25. She had microvascular dysfunction. So she was being treated inappropriately for this. And she was started on diastolic and had a significant improvement in her symptoms about a week and a half after. Not completely gone, but a significant improvement. The second patient was the patient that came in with chest pain. She had normal coronaries. She was told she had microvascular disease. No testing was done, and she was actually put on medication for it. So we brought this patient to the cath lab, and we started with doing the endothelial-dependent mechanisms. We gave acetylcholine. This is her baseline flow. Then we escalated it to 100 micrograms, and you'll see there she spasmed. So you look at the baseline compared to 100 micrograms of intercoronary acetylcholine, significant spasm, and she had EKG changes at the same time, and then it all went away when we gave nitroglycerin, and you'll see here. So that's a pretty impressive result, or a pretty impressive diagnosis of microvascular, vasospastic angina, and we're seeing this a lot in our patients that come in. And so we then did a microvascular test on her, and she had normal flow. She had a CFR of almost 7 and IMR of 5. Those are normal. That's normal augmentation. So she was diagnosed with vasospastic endotype and was started on a calcium channel blocker. And I believe she did start feeling better. So in summary, these are my take-homes to you. 1, chest pain with non-obstructive coronary disease is very common. You'll see the term ANOCA. ANOCA is associated with higher cardiovascular events. ANOCA has different endotypes: coronary microvascular dysfunction, vasospastic angina, myocardial bridging. Invasive testing in the cath lab involves evaluation for both CMD, the endothelial independent, and vasospastic angina, the endothelial dependent mechanisms, to identify the endotype and tailor the therapies. And then the future question, obviously, is does doing this testing and tailor therapy work, and does it improve symptoms and, more importantly, decrease cardiovascular events? Thank you very much.